So the first case is a 86-year-old female with ovarian tumor, and this is the peritoneal washing obtained during the surgery. So in this cytospin preparation, on low power, you can see there were aggregates of tight cluster with hyperchromatic cells. And when you go to higher power, you see the cluster, the cell inside this cluster do show marked polymorphism. So we do see these very big cells and with smaller cells arranging in a glandular pattern, and there is mitosis over here. This is compatible with high-grade adenocarcinoma. In the elder patient, it is most common as high-grade serous carcinoma. So we do have cell block for this preparation. Again, we see very similar finding. This is like marked polymorphism. We have a very big cell right next to a much smaller cells, and nuclear TPI, you see prominent nucleolus, as well as mitosis over here. So this is positive for adenocarcinoma. So the patient had ovarian cancer, and during the surgery, the surgeon identified that there were carcinomatosis, which is also very common for the high-grade serous carcinoma. So the next specimen again is also, it's the same patient, okay? So it's her second specimen. So this is from the same patient. So we see similar findings as well. So the next specimen is also a peritoneal washing from a patient with high-grade endometrioid adenocarcinoma. So this is a ascitic fluid, and you will also see this high-grade feature of adenocarcinoma. So we see three-dimensional cell cluster with enlarged tumor nucleus, prominent nucleolus, arranging a glandular pattern. So this is also positive. So the next specimen is relatively unusual. This was obtained from a liver cyst, a cystic lesion in the liver, and this is the fluid aspiration. So the most striking feature that we first see is actually this yellow bright pigment. This is actually biopigment. So when you see something like this, you know you are possibly obtain the specimen from somewhere with bile, because there's nothing in the human body will look like this color. So this is from a cyst in the liver. So you see the bile, which is kind of common. The most common specimen that we receive with the bile would be the bile juice obtained from the drainage. So in this specimen, we do see some bile, but we also see some mononuclear cells with enlarged nucleus, a little bit hyperchromasia. Some of the NC ratio, some of the cell, the NC ratio is really high, and it's a little bit hyperchromatic, and we see a little bit of coarse chromatin. So this is a bit unusual because it doesn't look like the normal hepatocytes. For the normal hepatocyte, the most like a fundamental cells in the liver, usually we will see low NC ratio with more granular cytoplasm, But here we see these pleomorphic nucleus with higher NC ratio and hyperchromasia. So these looks quite unusual. In the liver, they could also be malignant tumor arising from the bile duct, most commonly adenocarcinoma. But these also doesn't look very much like usual type of adenocarcinoma because we are quite familiar with pancreatobiliary morphology, but this is totally different, right? So the patient does has a past history of urothelial carcinoma. So this is, if you say you are in the urine, forget about the biopigment, this looks like high-grade urothelial carcinoma. You have higher NC ratio, coarse chromatin, and hyperchromasia. So I think this is the metastatic high-grade urothelial carcinoma in the liver. However, based on the clinical information, the liver cyst has been there for a while, for quite a long time. So I guess it could be a secondary involvement of a liver cyst of the metastatic tumor. So I think we would still need to confirm. So we would need to do a cytospin, and we would do a GATA3 because the original tumor was positive for GATA3. So we would do the GATA3 to confirm that this is actually coming from the metastasis of the urothelium. So the next specimen, we've seen these 3 days in a row. So this is small cell carcinoma. So we have higher NC ratio, cell in cell pattern. We have these like an Indian file pattern. Again, Indian file pattern, and with really high NC ratio. And if you check the nuclear chromatin, it is hyperchromatic, but you cannot see like nucleolus, and it is a little bit like a finely granular, these salt and pepper features. So this is a small cell carcinoma in the Purai fusion. So the next patient, Purai fusion, patient had a history of lung adenocarcinoma. So this is with a very high disease burden. We see a lot of these 3-dimensional cluster forming the glandular pattern. On high power, the tumor cells show classic nuclear feature with vesicular chromatin and the prominent nucleolus, cherry red nucleolus, and arranging a cell ball or glandular pattern. And you also see there is a cute psammoma body over here. So lung cancer can also develop psammoma body. This is compatible with the lung cancer. So the cell blood preparation also nicely show the similar pattern that we see. So the next specimen, we've seen the same specimen, and we've seen the specimen from the same patient yesterday. The patient had a past history of cervical adenocarcinoma, HPV negative, and histology suspect to be a clear cell adenocarcinoma, possibly from the endometrial cavity with secondary involvement of the cervix. So this is the urine specimen. Yesterday we find more cells. For these urine specimen, we only find these multinucleated cells, but the nucleus is quite bizarre, but also degenerated. So I think for this case, we can call it suspicious. But this is from the same patient, so likely this is also the tumor cell, but with degeneration in the urine. So the next specimen is from a CSF specimen. The patient had a past history of lung cancer. So lung cancer is one of the most common cancer that can metastasize to the central nervous system. So for these specimen, we do see these. Usually we won't see this high-grade morphology and the cell cluster, but in this specimen we do see this is high-grade adenocarcinoma. So it is compatible with metastasis to the CSF. So then we move to some fine needle aspiration. The first one is a bone aspiration from the same patient with high-grade endometrial carcinoma. So we see her ascites specimen. So this is the bone specimen from the patient. So in the bone aspirate, usually we will only see bone marrow element, which is usually hematological cells, very discohesive. But here we start to see some tight cluster. So this is more likely to be epithelial cell with cohesion. And the nuclear feature is very polymorphic. We have a smaller nucleus over here, another right next to it, probably 4 or 5 times bigger. We have prominent nucleolus. And here, this seems to be an individual cell necrosis with chororesis. So this is compatible with metastatic adenocarcinoma. So the next specimen is coming from the parotid gland. So on low power, we see a very large fragment of tight cluster. And when we go to higher power, the cluster is composed of these chondromyxoid matrix material with some oval to spindle shaped cells. So this is my epithelial cell in a chondromyxoid background. So this is classic for a polymorphic adenoma. So when we see these, sometimes we will see more epithelioid or plasmacytoid cells. These are also my epithelial cell in different shape. So the cytomorphology for my epithelial cell can arrange from spindle, oval to plasmacytoid myoepithelioid. So we can see a full spectrum of the cell morphology. Additionally, for the polymorphic adenoma, we will also want to see there are some ductal cells. Sometimes it's a lot of them when each cellular, but sometimes it's not. This is also a tight cluster for my epithelial cell, but with less chondromyxoid matrix. So here again, so we see similar finding. We do not see any ductal cell, but it is okay. And again, when we diagnose of a polymorphic adenoma, we want to confirm that there is no atypical cell suspicious for carcinoma, X polymorphic adenoma, or arising from a polymorphic adenoma. So this is benign tumor, and we didn't see any atypical cells. So the next specimen is a lymph node aspiration. The patient had a past history of thyroid cancer and received operation at the other hospital. So this is a neck lymph node aspiration. On low power, we do not see any lymphocytes, but we do see some colloid material and a lot of cell fragments. So this is not normal in the lymph node. And when we go to higher power, so this cell does has a nuclear feature of PTC. Particularly, you do see pseudo inclusion over here. So in the lymph node, this is the only diagnosis would be the metastatic papillary thyroid carcinoma. So the patient indeed had a history, so this is compatible with the recurrence of the disease. So here we also see another pseudo inclusion over here. Yeah, so this is positive for metastasis. Then we move to some US aspiration from the pancreas. So this one is a 60-year-old female. So in the US specimen, we will see sometimes the contamination from the intestinal epithelium, intestinal mucosa. So these looks relatively normal with a nice honeycombing arrangement. Very regular, the nuclear is uniform and the size is pretty small. So this is benign mucosal glandular cells. So right next to it, you start to see some dirty background. So this is compatible with necrosis, and you do see some histiocytes and engulfing with the nuclear debris inside the cytoplasm. And then you start to see some like degenerated cells with a nuclear polymorphism and atypia. So these nuclears, you see it's angulated, it's not rounded, it's enlarged, but the cell seems to be like degenerated. And so this is the necrotic debris that we see in the background. And then we start to identify some more tight three-dimensional cluster. The cytoplasm is quite plenty with some vacuolation, and it seems to be there are some mucin accumulation inside it as well. But when you go to the periphery, you can see that they are striking nuclear polymorphism. So this is what we call 1-to-4 rule. So you see one smaller cell right next to it, there's a much bigger cell, is around 4 times or bigger. So this is the diagnostic feature for adenocarcinoma. So you start to see some very atypical glandular cells with these 1-to-4 rule. So again, this is as well. When you only pay attention to this part, this still seems to be so-called honeycombing type of pattern. However, there are some slight difference between the usual honeycombing because you can tell for the regular honeycombing, the distance between each cells is the same, is regular. However, you start to see for these two cells it's getting very close, but these two cells getting apart. This is what we call Juncken honeycombing pattern. That's each of the cell is like moving around, so it is not regular. So this is a Juncken honeycombing pattern that is also very useful diagnostic clue, especially for the well-differentiated pancreatic cancer. The second thing that we know is that this is from the same cluster, and then you start to see these like a striking difference between the size of the nucleus. So this is what we call the 1-to-4 rule. So this cluster is diagnostic for adenocarcinoma because we see the Juncken honeycomb and as well as these 1-to-4 rule. So this is diagnostic. And in the background, we also see necrosis. So this is a pancreatic adenocarcinoma. So then finally, let's move to some pap smear. So we haven't seen squamous cell carcinoma for a while. So this is from a 74-year-old female. Usually for these patients, they were most commonly elder female patient who never received a pap smear examination. So when they come, they present with hemorrhage, vagina hemorrhage. So in the smear, you will see these like hemorrhagic background with some dirty granular debris. And when you go to higher power, So these are degenerated O blood. And then you also see a lot of degenerated cells. And then you start to find there are some weird looking keratinized cells, some without nucleus. And then you can start to find a few more like a strange spindle-shaped cells with keratinized cytoplasm. So these starting to get very suspicious for squamous cell carcinoma. And then you notice that this is what we call the tumor diastasis. So you find a lot of dirty nuclear debris, some with hyperchromatic feature, but mostly smashed, and throughout the entire background. And then you start to identify some cluster, looks more like high CO with coarse chromatin and high NC ratio. And these are all throughout the entire background. Okay, so this is very classic for a squamous cell carcinoma. So here is also more prominent, well-preserved cells. Again, so you see this cluster. You see a lot of nuclear debris, and all the cells looks atypical. So you find some more cells over here, and a lot of keratin debris as well. So this is classic for squamous cell carcinoma. The patient also had a biopsy, and it looks also like squamous cell carcinoma. They are waiting for the stents. So we can wait for the stent to come out, but this is classic for the squamous cell carcinoma. So you see these necrotic debris of squamous cells. So this is the classic tumor diastasis. So this is SCC case. So usually for the pap smear, we are looking for the precursor lesion. This is a 48-year-old female. So maybe it's at the perimenopausal stage, but still you see quite a lot of superficial cells. And then you start to find these like eye-catching kelocytes, which is very easy to identify because usually these are larger cells and with a nice contrast because the bright cytoplasm with a nice contrast, so it's easy to identify in the low power. And because it is usually sampled directly from the lesion, so it will distribute into a direction along the smearing, along one string. Unlike the squamous cell carcinoma, it's the lesional cell is all over the entire smear. But for the precursor lesion, usually it's only in one or two string along the direction. So this is low CO case. And this is a relatively elder female who is 72-year-old. So you can tell that the superficial cells is very scant, mostly intermediate cells. And we start to find a few of these vague kelocytic cells. The hyperchromasia is very minimal. The nuclear size is very similar to the adjacent cells. So this does not qualify a low CO cells, but with some atypia. In a relatively elder female, usually it is not very common to have a precursor lesion. However, we do see, I think this week or last week, 70-something-year-old female with a high CO. So we need to pay attention to this elder female. So again, this is quite unusual. And we have multinucleation. It's a little bit too much for the regular low CO. Hyperchromasia and some kelocytic type of feature. And this is the most striking cell. So I think for these elder female patient, we should still call these ascus. Okay, so this is an ascus case. So that's for all the cases.
Thank you.